So, good afternoon, everybody. Welcome to this satellite symposium sponsored by Philips Healthcare, which is entitled Echo in Heart Failure, Can We Do Better Now? So, very nice questions. I welcome also, of course, our participants online who will be able, as you actually could do also, place their questions in the chat. So, please do if you want. And my name is Nina Aymone-Marsan. I'm an echocardiographist from Leiden, the Netherlands, and I will chair this symposium with my friend, Professor Denisa Muraro from Milan, Italy. And the purpose of this symposium is actually to accompany you in the difficult journey of an heart failure patient, starting from diagnosis and ending up with therapy, and to see how echocardiographic tools can really help us to do better, to do more. We have an extreme good faculty, and we will start immediately with the first talk from Professor Pepe Zamorano from Madrid, who will tell us reaching out to heart failure patients wherever they are. Please, Pepe.
Thank you, Nina, dear Denisa, dear colleagues and friends. Indeed, I am delighted to be with you. First, because it's so nice to see you back again. But second, because I am sure that today we have a clear step forward in the field of echocardiography. Why am I saying that? Because what is the movie? It's the Fantastic Four. And it's true that premium echocardiography implies the Fantastic Four features. We have great imaging tools, great quality imaging. We have the TrueVue, the GlassVue, the auto-strain, the auto-right ventricular, MB, the heart model. Everything is perfect. But now we have a new starting era in echocardiography in terms of education and having a super expert always at possibility to interpret and to perform the echo. And this is with the compact 5500 CV. Seems like in the 5500 needs an excellent CV, which is now the compact, and the collaboration live. What is the collaboration live? And it's really what implies modern world, modern echo. It's simply the power of teleport. And teleport means that you get an expert in the room whenever is needed, wherever he is. And we have really experience in remotely connecting the super expert with a junior or a technician, will respond instantly to a question, and it clearly implies and much more, I will say, efficiency in the workflow. No doubt, I will say, is changing the remote diagnosis to accurate remote diagnosis. I'm going to show you in these 7 minutes just our experience with this collaboration live in the emergency room, in patients with heart failure, in the cath lab, or in the outpatient clinic. Our hospital, Ramón y Cajal, covers an area of 650,000 inhabitants, and we have outpatient clinics. Some of those are 12 kilometers away from the hospital. Well, how we did that, and what is our experience? Well, this is a patient. I was just taking care of a patient in the ward, but a fellow phoned me, noticed the T-shirt from Atlético de Madrid there, and the fellow just called me that she wants to scan a patient with heart failure in the intensive care unit. Then I can connect my laptop. Here is Sonia, is a fellow in training, but with experience in echo. And here with the React, I was able to see her, show the transducer. With the React, I can point exactly what we need to detect, we need to analyze. I told her, well, the contractility there is okay, but don't miss this part of the lateral wall. And this patient is an ischemic patient admitted with heart failure, and you can see here an aneurysm in the inferior basal aspect. This is one of the outpatient clinics that we have, as I said to you. And as you can see here, the fellow in training is doing the echo. I can speak with her. And the beauty now is that I can connect with the system with the same keyboard, with the same display, and I can manage, as you can see here in the display, I can manage the settings of the echo. I can cooperate in the diagnosis. I can simply run the speed, make the calculations. I can simply do the echo. It's not as it was with the React that I can point. Now here I can clearly interfere. I can clearly do the echo remotely. And this is another possibility that we have. Here is Covadonga, small hospital, and you can interact with the transesophageal echo, even with anesthesiologists that they may have a question or may have a problem. You can interact there and, again, interact with the system itself. You can really teach them remotely with an expert wherever they are. So what means the compact? The compact 5500 CV is all-in-one. It's excellent technical capabilities, excellent quality image, but what is more important is that you can connect immediately with an expert. You can make a new way of education with your technicians, with your fellows, and also you can always be there remotely, even handling yourself the equipment. No doubt that tele-ultrasound, in our experience in patients with heart failure, will unlock new ways to organize resources, and this is a new era of echo. We are moving from searching, looking after the perfect system for quality and imaging tools, and now the next step is telemonitoring in the society, in the new world. It can be a key tool to reduce variability of care, no doubt. The expert will always be there. Will mark a new age in education and increase resilience of the healthcare system against pandemics and unexpected conditions, and we have seen, sadly, in the last years. Thank you very much.
Thank you very much, Pepe. I'm indeed impressed, amazed. I mean, me as interventional cardiology, I would love not to go to the cath lab and get radiation. I would love not to go to a patient in isolation and improve education of my fellows. So the question is, what refrain us actually to implement this in the daily practice?
Yeah, well, I think that the main limitation is connectivity. I mean, the hospital needs a Wi-Fi that really connects in a fast way. But I think that this is a world infrastructure that is going to be changed. I mean, your car will need a better infrastructure with wireless, the world here, the system, the hospital. So I think I'm optimistic. Today, there is a limitation in connectivity. Will depends with the IT people, no doubt, and depends in your hospital. But I am quite optimistic because the world is changing so fast that internet, we will see and we will work with internet in a different way very soon.
But in your really actual experience, where is actually the place where you use it the most? Is really more in the cath lab where experienced operators are needed, or more?
Well, I think that in emergency units, when you need an accurate diagnosis and you are not there always, first. Second, in the cath lab, in difficult patients, or even with anesthesiologists that are not cardiologists and they have some doubts sometimes, I think those places may be better suitable for that. But it's like having an expert in your pocket.
Thank you, Pepe. That was really impressive. Do you think there is any application maybe in research, for instance, in large multicenter trials to standardize a methodology? Could be something, for instance, for remote centers?
Yes, this is a great point. I was not thinking about that, but I think it will standardize the way, and all these demo CDs that we do for training in trials, we can do that. We can use that teleport to harmonizing the measurements and the echo. I'm sure education will change.
Thank you. Any other questions from the audience? If not, we can switch to the next speaker. So we have seen what a remote control can do for our improving our quality in the Echo Lab. Let us see which is the state-of-the-art imaging in patients with heart failure, and which is the spectrum of high-performing tools that we can apply daily in the Echo Lab. Please, Victoria.
Thank you very much, Denisa, and thank you very much to organizers for the opportunity to participate in this symposium. Following the line that Pepe has just shown you, I will also like to see a little bit going what we have currently in clinical practice. It will be ideal that such a good quality of images can be achieved everywhere, because that would be kind of democratization of the use of echocardiography and how the technology can help centers from all over the world to get the standards that they are needed in order to diagnose and treat patients with heart failure. But we go very much according to what we know in the guidelines and what the guidelines recommend. And currently, the guidelines first try to phenotype the patient with heart failure based on the ejection fraction, and for those we could use a system with all the capabilities, but we can also even use a handheld system when we are in remote places or when we don't have that technology and we can assess the ejection fraction. But later on, we also need to know what are the underlying mechanisms that lead to that syndrome. And for that, we need much more assessment of the myocardial properties or the tissue characterization, or going much more, for example, into diagnosis of coronary artery disease that we know that is one of the leading causes of heart failure. How can we do a transthoracic echocardiography in the 21st century? How can improve the workflow? How can we improve the image quality and reduce the data acquisition time, the data analysis time, and to make it accessible to everyone? And here is where it comes artificial intelligence, not only implemented in the hardware, in the system, but also implemented in the workstation and the software. And I'm going to start with the algorithm that the guidelines recommend. We phenotype the patients with heart failure based on ejection fraction, with preserved ejection fraction, mildly reduced ejection fraction, or reduced ejection fraction. And you are seeing here only 4-chamber apical views, because I think that in the future we will reduce our time of data acquisition because we can generate the other views basically just pressing a button and without exercising our wrist. And for ejection fraction, we have been measuring basically the Simpson from the apical 4-chamber and 2-chamber view, and sometimes you see young fellows or technicians struggling to get a good view of the 4 or the 2-chamber view, but once we get a 4-chamber view, we just need to rotate, for example, the angulation without rotating my hand and get all the apical views that I need to measure the ejection fraction. But also we can acquire 3D echo data. And before we were used to change probe, so that was a limitation in order to acquire 3D data. And sometimes the image quality is not perfect. Well, we now have systems that can get a perfect image from the apical 4-chamber view. I don't need to change, I don't need to get another plane. And just with one button, I can get the volumes of the ventricle and the ejection fraction and also the left atrium. So this technology is helping us to reduce data acquisition and analysis. And we know that ejection fraction is also one of the main drivers in deciding which therapy to use in the different patients. From patients with preserved ejection fraction, where we have now these shunts between the left atrium in order to reduce the congestion, and patients with, who are candidates for a cardiac synchronization therapy or an ICD, patients who are candidates for transcatheter therapies, or patients who are candidates for left ventricular assist device as a destination therapy. Ejection fraction is considered the reference standard for prognostication of these patients, and this has been demonstrated in randomized controlled trials, but also on registries. But the question now with the therapies that we have is it really valuable to measure ejection fraction? Because with these 5 pillars that the guidelines recommend, the 4 pillars, actually all the patients with heart failure, no matter which is the ejection fraction that they have, they may benefit. So which are the patients that still perhaps they need a little bit more work? If I go back a little bit with the slides, sorry for that. So perhaps we need to go much more into myocardial mechanics. And here I put you two patients with reduced ejection fraction, more or less the same, one with severe mitral regurgitation, the other one without mitral regurgitation. And you can see that even having the same ejection fraction, global longitudinal strain, which we are familiar with now, can be differentiating these patients and giving the prognosis or refining the prognosis of these patients. This acquisition, again, from the apical 4-chamber view, 2-chamber view, and 3-chamber view, the system can recognize those views and can trace automatically the endocardial border and calculate for you the bullseye plot without you spending time doing the work. You have it implemented. And it's known that in patients with HFpEF, for example, from the TOPCAT trial, half of them may have a very reduced global longitudinal strain despite having a preserved ejection fraction, and the more reduced the global longitudinal strain is, the worse the outcome of these patients. So this tool is going to help us to better prognosticate the patients. Also gaining a lot of attention is not only the dimensions of the left atrium that we can also measure from the 4-chamber view and from the 3-dimension acquisition from the 4-chamber view. We can also use strain. And strain can also give us properties of how that left atrium is functioning, which is a buffer as well for the left ventricle. Now, moving to valvular heart disease that we also need to evaluate in these patients, we know that secondary mitral regurgitation is rather frequent in patients with heart failure, and secondary tricuspid regurgitation as well. And particularly for secondary mitral regurgitation, we have learned from series like from Mayo Clinic that there are different types of secondary mitral regurgitation. We not only have the one secondary to dilation of the left ventricle, but we also have the one secondary to dilatation of the left atrium with normal ejection fraction. Both of them, they have very poor outcome if we don't do anything. So how can improve the outcome of the patients with heart failure? How can we improve the awareness of the prevalence of secondary mitral regurgitation and to dedicate follow-up for these heart failure patients so that we can see which will be the patient with heart failure that will have or will develop secondary mitral regurgitation, and how we can select the best therapies at the right moment. So I think that one of the key questions always that we struggle in clinical practice is how do we quantify mitral regurgitation? And for that we are familiar with the 2D PISA, but certainly having now 3-dimensional echocardiography that can give us an end-phase view of the effective of the anatomic regurgitant orifice area, which has a very good agreement with CMR, is the way to go. And also if you use the 3D techniques, sorry for that, I'm not that familiar anymore with this keyboard. And if I go back one more so that they move, we can have the simultaneous view to assess the anatomical characteristics of the mitral valve. From this biplane view, from the short axis, I can scroll the entire mitral valve, see where there is the highest point of lack of coaptation, which seems that is in A2P2, and I can see the ventricular view of the mitral valve with a very thickened subvalvular apparatus. So those are all clues from transthoracic echocardiography in order to decide whether the patient could be a candidate for transcatheter therapies or no. The same happens with the tricuspid regurgitation. We know that there are many patients out there with severe tricuspid regurgitation and even with higher degrees of regurgitation, massive, torrential, and if we don't do anything, it's going to be a poor outcome for them. And there are multiple mechanisms, pacemaker-related, atrial fibrillation, pulmonary hypertension, left-sided heart disease. And the key aspect for these patients, in order to send them on time, is not only the symptoms, because we know that they are asymptomatic for a long time, but the right ventricular function. How we are going to assess that? Again, 3-dimensional echocardiography to see the anatomic orifice area, which has prognostic implications in these patients, but also to visualize the tricuspid valve as it will be doing, for example, at the operating theater. we can have the right atrial view, we can have the right ventricular view, and we can have the simultaneous plane or visualization from the right atrium or from the right ventricle with the dual view. And finally, we need also to evaluate the right ventricle. An evaluation of a patient with heart failure without an evaluation of the right ventricle is not complete. And particularly for patients in end-stage disease, where we have a therapy that can be an alternative for heart transplant, the evaluation of the right ventricle is very important. We are familiar with TAPSE, we are familiar with TDI, but it has limitations. 3D echocardiography, again, can give us the clue for measurement of the volumes and ejection fraction. So in conclusion, I think that comprehensive transthoracic echocardiography in heart failure is not only ejection fraction. We can get much more information, sometimes only from a 4-chamber apical view, and we can get this relevant information on myocardial tissue properties with myocardial strain, not only for the left ventricle, for the left atrium, for the right ventricle, and for valvular heart disease using 3D echocardiography. And that is without increasing the time of acquisition or analysis, and I think that I could have done that acquisition and analysis in the time that I've done this talk. Thank you very much for your attention.
Thank you so much, Victoria. Really beautiful presentation, and you have showed very nicely how complex, how comprehensive, and also versatile echocardiography has become nowadays. So one common problem for the clinician is to understand how the patient is going, the trajectory of the patient with heart failure. Is he improving? Is he stable? Is he going worse? So if you have all these long set of measurements of ventricular function and you have very limited time in your lab because you're very busy and you have to choose, which would be your most reliable set of parameters to monitor the ventricular function left and right for your patient in order to know that when you have a change, this is an actual change, it is not just maybe a measurement error?
Well, I think that you can shorten the protocol as much as you want, but then it will become 2 minutes. So that is the time that I need to say to the patient, how are you doing? And just listening to the patient, that sometimes they want to also us listening to them more than just go lay on the bed and I'm going to check your echo.
Of course.
So that's important. And I think that the algorithm that I provided is not very long. You can do all that in 10 minutes. You can shorten and go for the left ventricle if you want to focus that, because before the right ventricle, the calculations that you did were normal and you want to monitor how it's responding to the therapy. So then you have the apical 4-chamber view with 3D, and you know that the artificial intelligence tools right now, they have also reduced the inter-observer variability, but also the repeating evaluation variability in a way. So always acquiring with the same system can give you a much better evaluation of that patient on how he's doing sequentially. And I think that that's one of the key points.
Thank you indeed. These fully automated tools are really important to reduce the inter-observer variability in sequential measurements of echocardiography, which is a clinical issue with conventional methods.
Are there any questions from the audience? Yeah,
Sure.
I see one there indeed. Please.
Hello, Guy Lloyd, London. Thank you so much for an excellent, very clear talk. How do we as echocardiographers gain the confidence to start stopping doing things? How do we stop doing a full minimum data set that we would have done previously because we can add in 3D tools and abbreviate, do it much more efficiently and more accurately? When do we build that confidence into our work streams?
That's a very good question, a very relevant question. And I'm going to put for that, for example, the technology with CMR. CMR is evolving, and CMR is even recalculating what would be the normal values for a left ventricle, just because the technology has evolved so much that perhaps the values that were measured 30 years ago are not valid anymore because the systems that are used are different. So if we don't exercise in a way to see how this new technology works, we will never get that step forward in order to see if we can actually improve our workflow And if you just keep saying like this because that's the way we have been doing it, I think that is an assessment or a statement that goes against any innovation.
I agree completely. Thank you.
Any other questions? If not, I have a very small one. Of course, these are improvement of the workflow that help us really to implement it. But once we have these numbers, let's say, we are also working a lot on standardization of which are the cutoff and how to interpret them correctly, let's say. So what's your vision, especially in the strain measurements of how far we are in the setting the cutoff of normality, intervendors, etc.?
So that's also, again, a question regarding, we have been setting the normal values from various series. I think that now the artificial intelligence also has the capability to analyze thousands of data to see what would be the normal values again, perhaps more vendor independent. That's something that I think that all companies need to work together in order to set those normal values. But I think that global longitudinal strain has gone that far that we are relying much more perhaps on that measurement rather than on ejection fraction. We have ejection fraction because, as Joy was saying, is what we have been building and what we are familiar with. But we are moving also to see actually what I'm seeing is what is in the reality. Is there any abnormality that perhaps I'm missing? And therefore, it's experience that we build up. And I think that as long as the technology gets better, it would be good to reassess how we are doing, because perhaps we need to reclassify or reset those cutoff values of normality to make sure that we are really showing normal or abnormal.
Totally agree. We are just holding back on a biplane ejection fraction without the step further. Well, thank you very much, Victoria. And actually, as you already introduced in your talk, these tools are also extremely important to then take a decision on the therapy. And now we have, of course, all the possibility of transcatheter therapy, especially for valve disease, and therefore we switch to the next presentation, which will be done by the team, really representing what happens in the cath lab and imager and in interventional cardiologists. So we have Pedro Lee and Arzamendi from Barcelona, who will show indeed the fusion imaging in interventional treatment of left and right heart failure. Okay. Please, Pedro.
Okay, thank you very much, Nina. Once the patient is fully evaluated by Dr. Delgado and a valvular heart disease is detected, we are trying the cath lab to treat the patient with our most advanced tools. So fusion imaging is really clear. I think Echo Navigator gives us more information in the cath lab. Since the first releases, we are able to fuse the image. We are able to see the echo with the overlap with the X-ray. In this view, we can see on the left valvuloplasty, a percutaneous valvuloplasty. In the left side, the balloon is too ventricular, and in the right side, it's in the middle of the mitral valve. So the system gives us information about where is the target to treat. Not only that, new Echo Navigator step further and give us more information. It's able to automatically make the segmentation of structures. It can follow these structures during the cardiac cycle, and if we move the groove, it also follows all these structures. So with all this information, we are able to visualize as we like. In the left side, we can see a volume render, a 3D model with a massive TR after one device, after a percutaneous device for H2H repair. And in the right side, we have overlap to a color Doppler image after the second device with a moderate to severe TR. not only that, new Echo Navigator improves, fixes some mistakes from previous release. Typically, the system needs to track the shape of the proof. So when we move to transgastric position, it usually lost this tracking. So for tricuspid procedures, we need more and more the transgastric views. And with this new system, it makes easy and it fixes these mistakes even for tricuspid and aortic and mitral procedures. This is a case of rule out paravalvular leak after a TAVI procedure. But we can see clearly the detection and all the structures. We can see the mitral valve here. We can see the aortic, the prosthesis here. And also we are learning with this software. It could be a good teacher for us for improve the transesophageal technique. This is a very nice case. Same patient, same operator. Two very different images. What was happening? With Echo Navigator, we can see where is the proof. In the left side, our proof is not on axis of our structures. This is the mitral valve. On the right side, when we turn on the Echo Navigator, we move the proof and we try to be more coaxial with these structures, and it really improves the image for mitral regurgitation, for mitral therapies, but not only for mitral therapies, also for tricuspid. So because here in the left side, our proof it's very far from all this device, and it's off axis. So we need to try to move all this, all our system to be more coaxial with this the device, and we can improve with this image. In the left side, we have a shadow on the lateral way of the device. However, in the right side, our device is clearly identified, and we can be more accurate in the position of this clip. And now the interventional cardiologist perspective. David Artementi.
So Pedro, I think have showed clearly how these tools can improve our chest catheter therapies, but probably we forget one simple question, that it's that, and we have to take into account that the patients that we are talking about, they are patients with heart failure. So the first thing is that we need to understand is that we have to be really precise in our interventions. And why? So this is any surgical risk score in the same patient. We just have add heart failure condition to the B patient. And as you can see, just for adding heart failure, the mortality rate increases by 2. So this means that we don't need just to be precise. We might need to be pristine in our procedures so we don't get any complications, because otherwise the patients won't do well. So how can all these tools help us doing our procedures, improving our results? So as you know, one of the main steps for the transcatheter edge-to-edge repair is the transeptal puncture. So with these navigator systems, we are able just to point exactly where we want to do our transeptal puncture. This, we already had it with the first generation of the Echo Navigator system. What has improved So the thing is that with the new EcoNav system, we are able to have the volume of the heart. We have the segmentation, so we are able to see directly which is the reference from our transeptal puncture to the mitral valve. So just from the beginning, we can know if the approach that we are doing is going to be good or not. If you consider that this is not enough, the good thing of the tool is that as you see this blue ring, The blue ring is telling us which is the height of the transeptal. So it can go for 40, that is at the beginning reference, to 45, that is where we got the puncture, to 50. So just with this ring, we can already know if the approach is good. And not only that, we can just twist a little bit with our C-arm and see if you are completely coaxial to the mitral valve. That this would make the procedure much, much more simple. If there is any interventional cardiologist here, maybe he might think that most of the procedures are pretty simple, transeptal is easy, but there are some cases like this one with severe scoliosis. This patient was a 49-year-old guy that was refused for surgery because of this severe scoliosis. So we already predicted, as the surgeons do, that the transeptal won't be easy. And for this reason, these navigator systems are really, really useful. You can see here, we can see the regular explain of the septum, but at the same time, we have the marker. Pedro is pointing where we have to do the puncture. We have the ring marking the height that is going to be 45. We can see which is the reference with the mitral valve. And as you can see, the transeptal puncture was really difficult because the septum was small. We are puncturing really posterior, so we are like at 9 o'clock with a needle. And at the same time, you can monitor your pressure. You have all the same thing and just one single screen. So this makes the procedure much more safer. What else you have? That there are some other fancy tools that, when we get the GlassVue, it was something that it was good for tweeting probably, but we realized that it gives us much more information. This was a lady that she has a really small valve area, and the problem that we had with her is that she had a severe mitral regurgitation, and it was difficult to decide which was the widest part of the jet. So with the GlassVue, we're able to determine clearly whether we can have a better result with a single clip. What's the problem here? That if we need to use 2 clips, probably it will increase the gradient. If we are just doing tests with single clip on an elder people, the problem that we have is that we can tear the leaflet. So that's why we need to be precise. And here we realize that probably putting the clip in a position like a bit counterclockwise from 11 to 1, as we did, we could have a perfect result with a single clip. What else? So another fancy thing is the thing about the TrueView. It's also something that we really like, but how can it help us during the procedure? This was another old lady that she was refused for 10 times because she had a small estimated neo-LVOT. You can see a prolapse towards P2, close to the ones. The problem is that there is this scallop that is not a real cleft, that we know that when we crush their tissue, it's going to be difficult to analyze if we have enough tissue there. So, and we thought that the clasping was good, but if you check in the TrueView, you can see that we are missing part of the tissue on the posterior leaflet. So probably if we had to release the device, we will have a severe, significant jet at the end. So we decided to reposition the Pascal device in this case, and you can see just with repositioning and optimizing the posterior leaflet, we could have a good triangle just in the posterior leaflet, and this way we can release the device with more confidence and being sure that the result won't get worse at the end. And just to finish, another tool that we love a lot is the NPR. Why? Because, with the mitral, and especially with the tricuspid intervention, sometimes the echo probe needs to go up and down. We need to check the clocking with the 3D up. After that, we need to go down. We need to do the explain with the LVOT, etc. So then with the NPR, we can get all together. So the echo operator doesn't need even to move. We can see on echo 3D if we are completely perfectly aligned. We can see an equivalent of the explain. We can see if the leaflets are on the device. So this really helps to make the procedure much more shorter. Mm-hmm. And not only that, the good thing is that even interventional cardiologists can do an upgrade and become echocardiographers. This finger is my finger, so I'm doing as echo operator, and I'm just clicking, and I'm just deciding which are the views that I want to see. So I'm making a joke, but the good thing is that it makes the things easier for those operators, echo operators that are starting to support all these transcatheter interventions. So in conclusion, I think the EcoNav system increases the information in the cath lab. It improves the image quality during the procedure. As you see, Pedro showed how it can help to position better the echo probe. It improves it improves also the fusion imaging, and I think it's really helpful, as I said, for the transeptal puncture. I think the GlassVue is really useful to determine where the jet is coming. I think the TrueView can help us to assess the quality of the tissue that we are grasping and which is the exact quantity that we have inside the device. And I think with the MPR we have a quick check of the whole valve, and I think this is really, really useful. Thanks.
Thank you very much, David. A really nice presentation that helps us understanding how to use this tool in the best way. And indeed, I think you showed us that it helps the communication between the two of you go faster, safer, and therefore also to have better results, I think, of this procedure. So can we think of actually a clinical trial, like a comparison study with and without this technology?
That's a really good question, and this is something that we already have discussed. The thing is that we always compare it to driving. You know? So when you drive a car, now you all have these GPS systems that you use to drive and to arrive to the city that you want to go. The thing is that do you need a study showing that your driving is more simple, that you go quicker there, and probably even it's safer because it's going to show you which is the better track to go to the place that you want to go. So this is exactly the same. I mean, this is already a clear improvement. Do you need a randomized study for that? It's going to be probably difficult. I don't know if it's even necessary, because the problem is that when we got these sort of tools, we integrate them directly and we get really easily used to that. So if you ask me, to me it's going to be difficult to take it out from my hands now and to go back to what were you doing in the past.
Well, and I think you are the perfect example of interventionists embracing these technologies. Some others have the experience of sort of impatient interventionists that do not want to wait for fusing and etc. But just for curiosity, with this version, how long does it take to indeed fuse the image and be always in line with the view of the TE?
So Pedro can answer probably.
Yes, this new release, he needs to be patient because we need a core registration. It's a bit slower than the last one. But with this information, we have all the segmentation and all the 3D model. So we can work really fast, just putting the probe, putting on the system, and we can fuse. We can have the overlap image of the 2D echo and the X-ray, the more basic imaging. But the advanced imaging, we need more time, just a couple of minutes to take two projections, a registration, and it's a bit more difficult.
But it's pretty quick. I mean, it's pretty quick, and I think
see the perspective.
No, it's pretty quick because we used to. I think probably we are used to also to use the hard navigator, so it's pretty similar to the hard navigator. The good thing with all this system is also that he also can see in the screen what I'm doing. So sometimes we don't even need to talk. He's seen that I'm going up with the transeptal sheet, so he can see my fluoro, something that he couldn't do in the past. So he doesn't need to be doing that to see what I'm doing. So we can check what we're doing, and I think both of us gain with that, and I think this is really positive.
And this is valid also for the right side.
That's
because
right.
You show mainly left side, but you use it a lot also for the tricuspid valve procedures. Very nice.
Yeah, I think it's a really important point also because the tricuspid valve is much more complex and may have a variable morphology, may have up to 5 leaflets, so it becomes really important to not get lost and have references during the intervention. Any last question, quick question? If not, we have reached the end of this amazing session. You have seen how far we have come in the imaging of patients with heart failure. We have such a complex set of parameters that we can use in order to reach an early diagnosis and also to shorten the time to delivery of care Most importantly, these tools address the whole spectrum of patients with heart failure, from those that we have seen in outpatient clinics to the most complex cases in the Echo Lab. I would like to congratulate the presenters for the amazing presentation. It has been a really pleasure for me to participate and to chair this session together with Nina. Thank you very much and enjoy the rest of the Congress.